Hello, my name is Eve Rittenberg, and I'm really pleased to be here today to talk with you about interpersonal violence, trauma-informed care, and resilience. I do receive funds from the Robert Wood Johnson Foundation to do work in trauma-informed care. Before I start, I want to acknowledge that some of the topics I'll be discussing might be upsetting. So if you feel the need to take a break or pause, please feel free to do that. Today, our objectives are to describe the prevalence and health impacts of trauma, focusing on intimate partner violence, to identify the principles of trauma-informed care, to describe the components of effective inquiry into trauma, and then to define vicarious trauma and identify strategies to foster resilience. So I'll start with a case study. Miss A is a 35-year-old woman who comes into our office to establish primary care after being hospitalized with a sexual assault and diabetic ketoacidosis. She had a complicated medical history, including poorly controlled diabetes, PTSD, depression, migraines, asthma, and multiple physical injuries. So when you see a patient like Ms. A come into your office, what are some things that you might think about or want to ask her during this first visit? And in order to answer those questions, I want to step back and think about what we define as trauma. So SAMHSA, the Substance Abuse and Mental Health Services Administration, defines trauma with 3 E's. So trauma is an event or a series of events that are experienced by an individual as threatening or harmful, and that have lasting effects on their health and well-being. And those kinds of traumatic experiences can be understood on multiple levels. So, the ones that we are most accustomed to thinking about would be individual level traumas. So things, for example, like medical trauma. In the COVID time, we think about someone who experiences air hunger and then is intubated and in an ICU, and then afterwards might develop PTSD symptoms from that individual experience. We also think about interpersonal trauma, so things like intimate partner violence or sexual assault, childhood abuse or neglect. And again, that might have impacts on their later health. It's also important to think more broadly about trauma on a structural or collective level. So things like racism, homophobia, sexism, that likewise are experienced as threatening or harmful and have impacts on individual well-being later on. Just to again, sort of hone in on our terms, I think it's important to clarify the 2 different IPVs. So interpersonal violence, as I've talked about, that broad term for violence among individuals. And then in particular, what we'll be looking at today is intimate partner violence. So that is physical or emotional or sexual violence that is between intimate partners. And it includes a spectrum of controlling and abusive behaviors and physical violence. So the first thing that I think is very important to think about is how common these types of interpersonal traumas are. So sexual violence and intimate partner violence in particular. If you think about our patient, or if you think about just your waiting room, so say in a session you see 10 patients, there was large national surveys, so this one done by the CDC of over 10,000 people, in which over 40% of women reporting having had an experience of contact sexual violence in their lives. So that's not sexual harassment at the office or catcalling on the street, but this is unwanted sexual touch, attempted rape, or completed rape. So over 4 in 10. And then likewise, intimate partner violence was also incredibly common. So over 1 in 3 women reporting having had experienced intimate partner violence in their lives. So that's contact sexual violence, physical violence, or stalking. So you think about those 10 patients in your session, how likely it is that some of them have experienced these kinds of violence. The numbers are smaller, but not zero for men either. And then the second thing about sexual violence to understand is that it often starts young. So if you just look at these numbers, over 40% of women who reported that they had been raped in their life said that it happened first while they were children, so before age 18, and the vast majority before they were 25. So, as we're thinking about the impact that these types of experiences of traumatic exposures have on people, think about kind of the time when it's likely that they're starting, and the impact that that might have on them later on. The groundbreaking study in showing us how common early trauma is and the impact it has on health is something called the ACEs study. So this study was done in the late 1990s at Kaiser in California, and over 17,000 Kaiser patients received questionnaires asking them about their experiences of childhood trauma, abuse, neglect, or household dysfunction. So there were 10 categories in all. And then also asked them about whether or not they had a variety of mental and physical health conditions. And this study had two groundbreaking findings. The first was that almost 2/3 of people reported having experienced at least one adverse childhood experience. So incredibly common. And then the second was that there was a dose-response relationship between the number of childhood traumas and the likelihood of a wide range of adverse health effects later on in life. So what were those adverse health effects? Dozens of studies since that first ACEs study have validated its findings with results like this, that there's an increased risk for depression, PTSD, a 12-fold increase in suicidality. You might expect some of those, but it also finds significant increases in heart attack, stroke, diabetes, autoimmune diseases, a wide variety of adverse health outcomes. There was this one study published in 2009 that showed almost 20 years shorter life expectancy between people who had the most adverse childhood experiences, so that was over 6 out of 10, compared with people who had none. So again, if you kind of think back to those patients in your waiting room and how likely it is that some of them have had childhood trauma, and you think about the impact that those early experiences are likely to have on their health as adults when you see them, it becomes compelling as an argument to think that you need to start understanding how to inquire into trauma and then how to respond to it. I'm going to specifically hone in again on intimate partner violence. So here we also think about the acute harm from intimate partner violence, so over 2,000 homicide deaths each year in the US. More than 40% of women who are murdered are killed by an intimate partner. That many women who experience intimate partner violence have physical injuries as a result. But it's really crucial to understand that fewer than half of intimate partner violence survivors will seek health care for their acute injuries. Instead, what we'll see them with are those chronic sequelae. So just as we talked about with the childhood trauma and the increased likelihood of later health conditions, here also with IPV, we see increases in chronic pain, in somatic symptoms like gastrointestinal symptoms, in a variety of mental health disorders. Overall, we see a highly increased healthcare utilization rate among survivors of IPV, and often that's without obvious injuries. And so again, as you think about these patients who you're seeing with a variety of presenting concerns, it's important to keep in the back of your head, what are some of those traumatic exposures that might be contributing to their presentation when they see you, even if it's not an obvious black eye or broken bone. I'm also going to just touch briefly on the broader structural violence that we are becoming more aware of as a country. For example, the rates of police violence against Black Americans. And we think here too about the immediate trauma, the deaths that are due to this structural violence. We also think about what are the chronic sequelae of the day-to-day racist experience that people undergo. So again, thinking about a trauma lens to look at these different levels of violence. So how does that happen? You know, if we want to understand the ways in which adverse health consequences result from traumatic exposures, we need to take a look at the body's stress response. So I'm going to just touch on this very briefly. There is enormous amount of ongoing research into these physiologic mechanisms. So we think about our brain sensing danger. So there's some danger or threat presented, and our amygdala will fire in response and will communicate with other areas of the brain. So for example, we'll send signals to inhibit some activity in the frontal cortex. It will also communicate with our endocrine systems. So we'll send signals to the hypothalamic pituitary axis to start pumping out the stress hormones, so adrenaline and cortisol. We'll also have interactions with our immune system. We're learning more about epigenetic results of traumatic exposures. So through this response, this complex response, our brain will contribute to our behavioral responses, so to our fight, flight, or freeze responses. So if there was, for example, with a prehistoric person getting chased in the woods by a bear, our amygdala would fire off, we would pump out cortisol and adrenaline, our blood pressure would go up, our heart rate would go up, we'd have more sugar available for energy, and we'd be able to run really fast, or we'd be able to fight the bear, or be able to freeze and it wouldn't see us. And then when that acute danger passed, when the bear went away, everything would return through this nice negative feedback loop back down to normal. The problem is when the traumatic exposure, when that threat is chronic and doesn't go away. And instead, our body responds with this sort of dysregulated response. And that dysregulated stress response is also known as the allostatic load. So we're producing cortisol, we're producing adrenaline, we're responding in ways that are not nicely regulated as before, and that has negative impacts on our health and well-being later on. So I'm going to switch and just think about our role as healthcare providers. Why should we think about trauma? I hope that I have shown you some evidence about the pervasiveness of trauma among both patients and ourselves and each other. And also that trauma has large impacts on our health and mental health. I also would suggest that trauma influences the ways in which people experience and engage with healthcare. And that's because healthcare itself can unintentionally be re-traumatizing to people. So why is that? Despite all of our best intentions to be good people and compassionate providers, people come into our offices with their cumulative lifetime experiences. So they may have had negative experiences with a healthcare provider in the past. They may have had a painful procedure. They may have had a distressing diagnosis, and they bring that with them when they come to see us. In addition, our patients come in with backgrounds of cultural or historical trauma. So we think, for example, about the Tuskegee experiment and the impact that that has had on the reality and perception of healthcare ever since. When they come to our offices, there's a lot of confusing medical jargon. There may be things they don't understand. There's a lack of privacy. And then we ask them questions that may be embarrassing or hard for them to think about. There's physical touch. We ask patients to take their clothes off and put on these little thin gowns. They're in vulnerable physical positions. And then procedures, which we think of as totally routine, putting a blood pressure cuff around someone's arm or doing a pelvic exam, those are not routine experiences for everybody. And so for all of these reasons, healthcare visits may be very hard to tolerate for people who have high loads of previous trauma. And so to respond to this, to try to think about how to provide healthcare in a way that meets the needs of people who have had traumatic experiences in their past or that are ongoing, it's important to shift. So away from our traditional way of thinking about people as what's wrong with you when they're doing things that we don't understand. So if someone is not taking the medication that we prescribe, or continues to smoke even though we've told them that it's bad for their health, or gets angry in the waiting room when they're told that their provider is running behind, and to shift and think about why might they be behaving that way? What are the things, the experiences they've had, and how is it affecting their health, well-being, and their ongoing behaviors? And that's a shift from a deficit model to one that really focuses on people's strength and resilience, one that partners with patients rather than sets up a power dynamic of the doctor kind of telling the patient what to do. This model is called trauma-informed care. And again, SAMHSA has defined 6 guiding principles for trauma-informed care. I'm just very briefly going to give maybe an example for each one, but this is a framework for how to think about your interactions with patients, or how to create an environment that allows them to engage with care, and how to understand some of what's driving their behavior. So the first principle is safety. So think about, for example, how to create a physical environment in your office that fosters a sense of safety for patients. So we typically put people into these small enclosed exam rooms and shut the door and leave them in there by themselves. That can be very difficult to tolerate for someone for whom being enclosed in a small space was used as a punishment, for example, being locked in a closet when they were young. And so offering a choice, would you like the door open or closed? Just that simple act can help people gain a sense of safety during that medical encounter. For trustworthiness and transparency, we want to think about the language that we're using. So how are we talking about patients? What's the stigma in some of the ways that we've been talking about them? So, calling someone a frequent flyer or an addict can be very harmful to patients. And when patients are able to see their records, so for example, with open notes, really thinking about the ways in which we talk about patients and describe what they're going through are very important for patients to see, because they may fear some of that stigma and bias from ways that they've been talked about in the past. Peer support, so encouraging both our patients to find other folks like them to turn to outside of the doctor-patient relationship, but also in recent days, the importance of peer support for ourselves and each other has become very salient. So thinking about during COVID, how are we able to draw on each other to get through these hard times? Collaboration, teamwork, so things like shared decision-making with patients, empowerment. So, again, rethinking when you're with a patient, speaking to them at eye level rather than standing over the bedside can help people feel empowered to participate in decision-making on an equal level, providing choices, options for treatment. as opposed to just deciding and prescribing on your own. And then finally, having an attitude of cultural humility. So being ready to learn from your patients and try to understand them in their particularity and across these different dimensions. So to get back to inquiry, I think it's important to focus on the fact that you are not trying to get a disclosure with all the details. That's not the goal when you're asking about trauma. You want to provide an environment that people feel comfortable sharing with you what they choose to, but you don't need to get all of the details. And in fact, often helping people contain the emotion around the trauma is more helpful than pushing for details. So when you are asking or inquiring about trauma, make sure that you include some education about trauma, normalizing it, perhaps saying what you're experiencing is a normal response to abnormal circumstances, for example, and balancing trauma with resilience. So asking and then documenting what are people's strengths? What gives them a sense of peace or safety? What do they use for supports? And in doing this, sort of the mechanics of this, we should think about starting with broad inquiry, broad questions, and then as needed, focusing in on assessing risk, assessing safety, and making interventions as needed. I'm going to use this broad framework and move on to inquiry about intimate partner violence in particular. So we all know we're supposed to do this. The United States Preventive Service Task Force gives a grade B to intimate partner violence screening for all women of childbearing age. There are many tools out there, so 3 to 5 questionnaires to probe for intimate partner violence. We also know that not everybody feels comfortable filling out one of those questionnaires or answering the questions with a provider who's looking at a computer with their back to the patient. And so think about how to effectively inquire and provide options for building resilience and safety for patients. Let's think back a little bit to those principles of trauma-informed care. So how do we set up a safe environment? First, you want to make sure that you're speaking with the patient alone. If this is in person, having some way to get the partner out of the exam room is really important. In this era of telehealth, my sense is that we need to assume that people are not alone. And so focus more on providing universal education, providing resources, rather than asking a lot of questions when someone may be able to hear what your patient is saying. Important that you know your state's laws about mandated reporting and confidentiality, and then are transparent with your patient about those limits upfront before you start asking questions. Starting with some open-ended questions. So absolutely do the screens, and I list some of them here. But when you're talking with someone, you can ask a question like, so tell me about your relationship. And then follow it with something like, do you ever feel unsafe with your partner? Or what might happen if the two of you disagree? And then, take your cue from the patient. Pay attention to their body language, pay attention to what they're saying to you and their comfort level. And either be prepared to respond yourself with a danger assessment, and there is a validated tool for that, with a safety plan so you can help them plan for how to mitigate their risk. And if you're not able to do that, either because you're not comfortable with that, or you don't have time, or the structures that you work in don't allow that, have somebody who you can make a warm handoff to. Who can you connect the patient with to ensure that they do get that follow-up that they need? And then if possible, if this is a patient who you will be able to see in the future, let them know that there's no judgment or stigma here, and that they can come back to talk with you if they want. So I'm going to pause here and ask a question. So what which of the following are helpful phrases that you might use when a patient discloses trauma to you? And you can choose as many of these as seem correct. Okay, so all of these. So first, just letting a person know, I appreciate you sharing that with me, and that I'm sorry. Um, Making people sort of validating that this isn't the person's fault, and then going into what that patient's priorities and needs are. What do they think that they need at this moment? Okay, so back to our case. Um, Ms. A disclosed that her ex-partner had raped her just prior to this hospitalization, and that previous to that, he had been abusive to her over the course of their relationship for the past 4 years. In the context of that, she had stopped taking her insulin regularly and had multiple visits to our emergency department. During this hospitalization, though, she was connected with folks who were able to help her engage with the healthcare system. So, to a domestic violence advocate, to someone from the care clinic, which is a resource at our hospital, and to a primary care physician. And so, as we think about those connections, I want us to stop back and think about us. So we ourselves as healthcare providers are also people who have experiences of trauma and adversity. And I'm going to just pick out a couple of areas for us to talk about. So one is the Me Too movement. In the context of this movement, Jagsy et al. Did a study a few years ago looking at academic uh, women physicians who reported that over 30% of them had experienced sexual harassment or discrimination at work in the past 2 years. Also want us to think about how we are experiencing the effects of COVID-19 and the trauma and moral injury that healthcare providers as a whole have experienced in caring for so many patients, um, often with inadequate protection for themselves, with worries about their own health and safety and that of their families. And as we think about, in addition to our own personal experiences, and as we think about that, the question comes of how can we create space for our patients to share their stories with us while we're also taking care of ourselves? And in order to answer that question, I'm using this framework here from the Office of Victim Services to think about what we call vicarious trauma or work-related trauma exposure. So hearing other people's stories, bearing witness to other people's suffering and the effect that that has on us as healthcare providers. And we know that those experiences produce changes in our worldviews. So if you were lucky enough to grow up thinking of the world as a safe and benign place, hearing these stories, seeing the suffering really changes that. And we can have a spectrum of responses ranging from the negative, what we call vicarious traumatization, that produces symptoms that are similar to PTSD, so hypervigilance or flashbacks or numbness, called compassion fatigue. All of those symptoms are part of that vicarious traumatization. However, we can also have what we call vicarious resilience. So we can find meaning and purpose in taking care of people who are suffering, can have compassion, satisfaction, so feel better in our world and in our work because of what we're doing. And the question is, how can we mitigate those negative experiences and strengthen or bolster the positive ones from the work that we do? Again, I'm going to pause here and ask a question. What is the definition of secondary or vicarious traumatization? Right. And the answer is traumatization through indirect exposure, such as narrative, hearing people's stories. So I asked before, how do we bolster that resilience? And you can think about this both for patients and for ourselves. So some of that is very much the mitigating that, that toxic stress response through eating in a healthy way, through regular exercise, through regular sleep. through meditation or the relaxation response, as well as the emotional and cognitive tools, looking at life in a positive way, focusing on the things that are going well, building a network of support. All of these individual factors can mitigate some of the harmful effects of traumatic exposures and strengthen resilience. I'm focusing here on individual resilience. There is also a large body of research going on for community resilience. So what are the levers to strengthen community response to traumatic exposure? And because of time, I will not go into that here. I do think it's important, though, even with individual resilience, to think about how that is part of an environment. So this is my colleague, Nomi Levy-Carrick's graphic of thinking about resilience in healthcare providers, that it's important for us to have role clarity, to know this is my lane and this is not my lane, in order for us to be able to function with resilience in our work. To have self-efficacy, so to have the confidence and strength that we have the skills we need to do the work that we're supposed to. And then finally, to be empowered really by our system to have the resources that we need. So think about that as, PPE or technical support or training or the ability to take a break when we need it, to be empowered to do the work that we do. So even individually, we function in a system to have resilience. And I'm going to end with our case study. So she still has challenges with health, but has been able to engage in her care with a primary care doctor, also with specialists and with a therapist. And so she is starting to see progress in her own health, into mitigating some of those adverse effects that she has experienced stemming from the trauma that she has endured throughout her life. So in summary, I'm just going to end with that trauma is common and has wide-ranging impacts on health. That effective inquiry about trauma occurs in the context of a relationship, and that trauma-informed care provides an approach that can improve engagement with patients, mitigate the effects of trauma and vicarious trauma, and work towards health equity. Thank you.